Good evening, everybody. Welcome to this webinar. I should introduce myself first. I'm Sheila Baroness Hollins, a crossbench peer, and for tonight, the reason that I'm chairing is because I'm president of the Catholic Union. I'm going to introduce each of the panelists as it comes to their turn to speak, and we're going to be addressing the question that hard cases don't make good law. Okay, so there are one or two little housekeeping details. The first is that if you have a question that you'd like the panel to address later on, then please can you put it in the Q&A rather than in the chat. It's more likely to be noticed and picked up if it's in the Q&A. Okay, and we will finish promptly at 8 o'clock. And if we don't manage to get to your question, I'm really sorry about that, but we will do our absolute utmost. It's a particularly important moment to be addressing this question because the Terminally Ill Adults Bill, Private Members Bill, finished committee stage earlier this week, and it will, after the Easter recess, move on to its next stages in the House of Commons. And we've got an excellent panel of speakers to address some of the issues that are that need to be addressed and thought about carefully as we face this very important debate in this time in history. So, first of all, I'm going to invite Dr. Matthew Doré, who's a consultant palliative care physician, to speak to us. And Matthew is a palliative care consultant in Northern Ireland at a hospice in Belfast, past chair of the Palliative Care Congress, honorary secretary of the Association of Palliative Care Medicine. He spoke very well at the Catholic Union's well-attended panel discussion last year, and has spoken quite a lot in the media about this issue. So I'm really looking forward to hearing from you, Matthew. Over to you.
Thank you so much for inviting me and for the introduction. Good evening. I want to outline and articulate as clear as I am able to what the Terminally Ill Adults End-of-Life Bill really does to people on a population level. Before I do, I have to mention I've watched most of the committee stage and I've been appalled actually by the parliamentary standards at this committee stage, the politicking and the dissociative way in which they have dismissed any concerns raised as obstructive. Albeit I don't watch many Westminster committees, and I sincerely hope this is an exception rather than the rule. But it has shaken me up in the confidence I have in our systems and structures that ideology and lobby groups have such a sway. To outline legislation for assisted suicide effect on a population has a dual purpose. One, to fully understand how we can argue against it, and two, because I want you to articulate this to your MPs and leaders. Please, in person, visit your MP urgently. They may not know what they are doing. The proposed legislation allows individuals over 18 residing in England or Wales who are deemed terminally ill with a prognosis of fewer than 6 months to request assisted dying, aka lethal medications to self-consume or inject, i.e. assisted suicide. They must go through a capacity assessment to make this decision, which we'll talk about in more detail. There are non-defined terms such as clear and settled wish, which neither defines what clear means nor settled. And the given definition of terminally ill includes those that when stopping a treatment means they deteriorate to a shorter prognosis, such as diabetics stopping insulin, and those many chronic illnesses, including anorexia nervosa, which was seen by the committee as an acceptable collateral damage. I want you to hold one question in your mind, and I'll repeat it a few times. Please ask your MP, how many incorrect deaths justify the right to access lethal medications? A core argument from a doctor's perspective is assisted suicide a medical treatment or not? This, I admit, initially sounds pedantic, but bear with me. The legislation certainly heavily implies it is a medical treatment. Doctors can suggest it, doctors assess for it, doctors outline it, and doctors prescribe it, and doctors give it. But I put it to you, assisted dying suicide is not a medical treatment. So, Matt, what is a medical treatment? Fortunately, this has already been described. A good geriatric research paper outlined a medical treatment as having 4 pillars. I'm going through them really quickly. Restoration, means end proportionality, parsimony, and discretion. Okay, what's that mean? 1, restoration. Medical treatment aims to restore equilibrium. But in assisted suicide, surely death is not a state of restoring equilibrium. Means end proportionality. Treatments should be tested and adjustable, but death can't be trialed or titrated or reversed. Parsimony. Minimal intervention should be used to achieve therapeutic goals. But is death a proportional response? Discretion. Decisions should be made with evidence and caution, yet the evidence supporting lethal medications is near none. So assisted suicide doesn't fulfill those 4 pillars. Then there is the most important dynamic of a medical treatment. That is, a medical treatment can't be demanded by the patient. You can't demand antibiotics, for example. A medical treatment is indicated by the doctor's discretion on your presentation, your symptoms and tests. It is the doctor's choice of what to offer you. That is why we have prescriptions. Now, you can always refuse a medical treatment once offered, but you can never demand one. That's a service. To reiterate, you can't demand chemotherapy or surgery. You can't even demand resuscitation. Yet assisted suicide in this bill is something you can demand from a doctor. It's outlined that a doctor must find someone who will assess and do it for you. This is different to any other medical treatment. But it's got safeguards, doesn't it? Well, they're not really safeguards in any true sense of that word. There is no clinical judgment involved. They are, as outlined in the bill, a criteria of eligibility. They form a circle of people who are eligible. Over 18, check. Terminal illness, check. Capacity, check. Unlike any other medical treatment, there is no indication, but a criteria. Assisted suicide doesn't have safeguards. It has an eligibility criteria. This is another difference. There is no medical treatment which works by an eligibility criteria alone. Think about it. All medical treatments are by indication. So what is the difference? Eligibility is whether a person qualifies something based on a predefined criteria. An indication is whether there is a reason or justification for a particular action or intervention. The only partial eligibility criteria I can possibly think of is in transplant medicine, which does have some age cutoffs. But this is very, very rare to have a medical treatment which has an eligibility cutoff, because this would be seen as discrimination, such as ageism. Almost all medical treatments are based upon a judgment by the doctor fulfilling all the 4 pillars mentioned earlier, with no predetermined criteria of eligibility. But proponents say, we do a capacity assessment to check they can make a choice. But then the capacity assessment is completely mismatched to purpose. The Mental Capacity Act capacity assessment is not designed as a gateway to a treatment. Never have. Listen to that again. A capacity assessment is not a gateway to a treatment. Indeed, the Mental Capacity Act outlines the doctor must assume someone's capacity, which interestingly, we don't when applied to assisted suicide. Normally, you only do a mental capacity assessment if you suspect the person is confused and they are making a decision against medical advice. The capacity assessment is to protect people who are confused, that we as doctors are not doing something to them which they don't want. Think about it. We do a capacity assessment in someone we suspect is muddled if they want to leave the hospital or go against medical advice. You can make unwise decisions when you're not confused. And if you are confused, it's a best interest decision, which is a joint decision with consideration of the patient's past decisions and their family and the wider MDT, the multidisciplinary team. To reiterate, it is to protect those who don't have capacity, not fulfill the wishes of those who do. What it is not is a check, a test, a gateway to get something done to you. Do you see the difference? This bill uses capacity as a pseudo check, mismatching its whole purpose. But it sounds good, doesn't it? The patient has capacity. Indeed, I'm sorry to say this, but it gets even worse. An amendment to require exploration of why do you want assisted suicide, why the patient is accessing lethal medications, was rejected. There is nothing in this bill to outline why the person wants it. Indeed, it was stated at committee, it is no one's business to ask why they are seeking lethal medications, as long as they fulfill the criteria. In all of medicine, the why of the patient making a decision, exploring what and why, comes first, and then a treatment by the doctor is decided by indication, which is then negotiated and agreed with the patient. However, in assisted suicide, a demand for assisted suicide is made. Doctor is required to oblige, do, or refer, and no reason why explored. Even if the why is explored, whatever is said, irrespective of concern, has no bearing on the outcome of fulfilling the eligibility criteria. If you fulfill the criteria of eligibility, no questions asked, you can access lethal medications, is the bill's ethos. So my question becomes, who else fits within this criteria of eligibility? So imagine a big circle. Who else is inside this right to have lethal medications? Well, it is all my patients. It is essentially all palliative patients, which is why specialist palliative care is overwhelmingly against this. Let's go through some really quickly. Mentally unwell. Think of this. How do you tell the difference between a suicidal patient without a terminal illness compared to one with a terminal illness? Are we saying those with a terminal illness can't be suicidal? I should stop those jumping off a bridge if they don't have a terminal diagnosis, but nudge those off who do? There is no requirement for a psychiatry assessment. And indeed, this modified judge minus model has the psychiatrist questioning the assessing doctor, not the patient. To repeat that, the psychiatrist is prevented from doing their clinical assessment, as does not assess the patient, rather assesses the doctor who did the assessment. This, despite the wordplay, is not a multidisciplinary team assessment, in which the professionals do their professional role in assessing the patient and coming together for a joint plan. Rather, the panel are assessing another professional's assessment and with no real powers to question it. What about burden and coercion? Well, just say coercion is real. 1 in 6 elderly have experienced abuse. Laws are not for wealthy white celebrities, but for everyone. Just last week in the news, there was a brother and sister who illegally edited a will to get money through an elderly relative. And burden is even harder to pick up. How do you figure out which patients feel a burden on family and friends? Indeed, in Oregon, 43% outline the reason they're having lethal medications is because they feel a burden on family and friends. Is this an acceptable number? Certainly not small. How many people, rather than lose their house to pay for their care needs in, say, a nursing home, want to give this money to their kids? This is arguably the ever-growing cohort that ever increases the number of cases in legal jurisdictions as the culture shifts to when a person's self-worth of life becomes a question. Again, I ask, how many of these incorrect deaths are acceptable for this right to assisted suicide? Misdiagnosis, misprognosis. Medical predictions of life expectancy are often very inaccurate, especially when in terms of months, no better than flipping a coin. How many people would have incorrectly killed themselves early, having fulfilled the criteria? Now, I wish Esther Ransom the best, I really do, but she fulfilled the criteria 2 years ago. How many people in her situation would have already accessed lethal medications? And it is scary to think about diagnosis as well. Do we get it wrong? Of course we do. It's not uncommon. Just a few years ago, we got many motor neuron disease diagnoses wrong in Northern Ireland. How many of these would have accessed lethal medications incorrectly? My point is the cost of a right to have a criteria of eligibility to access lethal medications is inevitably we kill incorrect people. To quote the very honest reflection of the proponent and patron of the organization My Death, My Decision, Dr. Henry Marsh, quote, they argue that grannies will be made to commit suicide. Even if a few grannies get bullied into it, isn't that a price worth paying for all the people who could die with dignity? To finish off, I want to ask the question, what happens if we put every possible safeguard in place? Have we got an example in which every possible safeguard is enacted? Is that safe enough, Matt? Well, we do have an example, actually. The UK abolished capital punishment in the 70s on the basis of wrongful executions. We hung the wrong people who were subsequently proven to be innocent. This is despite all safeguards possible. A full court process, judge, jury, months, even years of deliberation, witnesses, access to finances, records, all those things. Yet we still killed incorrect people. The process made mistakes. Thus, for an irremedial act, we decided we can't make those mistakes in law. How many more mistakes will this process make with far less scrutiny? How many incorrect deaths is acceptable as a society? Does the circle of eligibility expand? Yes, it does. Looking at international examples, we see expansion of eligibility criteria in every jurisdiction that has it longer than 10 years. Once assisted suicide is legalized, the eligibility criteria becomes about an argument of discrimination. How can you have a medical treatment which is ageist or discriminates against those suffering longer with chronic illness or those that don't have capacity with dementia? You see how embedding it as a medical treatment inevitably causes it to expand. I've talked long enough. In my final reflections, an eligibility criteria defining those who can access lethal medications will kill many others who also sit within that circle. Assisted suicide blocks palliative care, as the nurse or doctor is seen as blocking access to a service, blocking a right the patient has, especially if the palliative care nurse tries to address the underlying reasons why they're asking for it. This is the largest societal change and a change in the value of life this nation has ever seen, I think. I implore you to speak to your MP urgently and encourage many others to do so. Outline that this is not a progressive thing, but a retrogressive step in care and compassion to a population. Ask the one simple question: how many incorrect deaths are acceptable to you for this right to have lethal medications? Thank you.
Thank you. Thank you very much indeed. That's really given us a lot to think about. Thank you, Matthew. I'm now going to introduce our next speaker. Oh, and by the way, don't forget to put your questions as you think about them. That would be really, really helpful. So Professor Julian Hughes. He's honorary professor at the University of Bristol, former consultant in old age psychiatry, honorary professor of philosophy of aging at Newcastle University, editor, very importantly, of The Reality of Assisted Dying, Understanding the Issues, a book that has been distributed widely to parliamentarians throughout the debate, and I have to admit I got a chapter in it. Julian, you're going to talk to us about well-coordinated end-of-life care, and I'm really looking forward to hearing that. Over to you.
Thank you very much. Can I be heard okay? Yeah. So I just very quickly was thinking about the title of the whole webinar about difficult cases make bad laws. I'm aware that some jurisprudence people dispute that and think that that might not be true. I don't want to get into that because I don't know enough about the whole subject. But what I want to argue, the sort of background to what I'm saying, is the thought that ideas that are morally bad and unsafe are going to make bad laws. I think that Matt was absolutely right to emphasize the importance of thinking about incorrect deaths. So having said that, the three things that I'm going to cover are, first of all, something about palliative care. Then I'm going to say a little bit more about coercion, following on from some of the things that Matt said. And then finally, I'm going to, I'll just have some concluding comments, which will be something to do with George Orwell. But let me start with palliative care, first of all. So some straightforward facts. Matt will know this very well because it's his area, and I apologize to him for talking about something he could talk about much better, I'm sure. But we know that about 75% of people dying in the UK require palliative care. And Hospice UK have said that over 100,000 people die needing palliative care, but not receiving it. That need is going to increase as the population ages. And we also know that palliative care is under-resourced and understaffed. So in essence, we need to have more palliative care, but we also need to have better palliative care. And one of the key things here, which I think has to be underlined, is that we need more research in palliative care. We need more research funding for palliative care. The relative funding is not good. And what we mustn't do is have some sort of what could be called therapeutic nihilism, the thought that because something isn't working, therefore we've got nothing else left and we just have to resort to assisted suicide. You wouldn't think that for most other conditions, and I think there's no reason to think it about palliative care. So we need to have innovative approaches. And one of the things that's impressed me during in some of the papers that have been written about all of this is the thought that we could have more interaction between palliative care services and pain clinics, because it might be that anaesthetists who tend to run pain clinics will be able to add to the knowledge and expertise of people in palliative care. I think we also need to have further consideration of the proper use of palliative sedation, which is a controversial topic, but I think it's well worth thinking about, and it may well be the solution for some people who are in pain. And then more generally, I think we have to have a better understanding of how far clinicians can go in terms of relieving pain and discomfort. I think that, especially after cases like the Dr. Shipman case, people are nervous about providing really good palliative measures to people. And I think here, I think we could get into quite deep discussions about foreseeing and intending treatments and so forth. But I think in some ways, I think that those discussions, although sometimes irrelevant to routine treatments in palliative care, I think actually they're very important for us generally to think about in medical terms. I want to move on just to say things about coercion. So in the amended bill, that's the bill that's come out of after all the committee stage, it repeatedly has phrases like saying that you have to make sure that the person has not been coerced or pressured by any other person. And it talks a lot about training doctors to know whether a person has been coerced or pressured by any other person. So the first thing I want to do in response to, so that's meant to reassure us that there's going to be training and we'll pick up coercion and so forth. But I want to question that. One thing I want to say, without sounding too cynical, is I'm unsure about the reality and quality of such training. I'm sure that the people who will devise this training and deliver it will be doing the best that they can. But all of us who've been through statutory and mandatory training in the NHS know that often this is done simply by sitting at a computer, pressing buttons in response to multiple choice questions, and you can go back and forward through this sort of thing. And even when there is face-to-face teaching on these things, it's sometimes, if we think of things like the prevent the prevent courses that were given to stop stop terrorism. I mean, people used to go and sit through those courses and then go off but do these things actually work? To what extent do they really convince people? And what would we really need if we were to have proper training for people to allow them to pick up coercion? Well, we'd certainly need therapeutic relationships, but in the bill, it might be that the two doctors who have to write the recommendations have never met the patient before. We certainly need to have genuine engagement, I would say, over time. We'd normally want to have a variety of reports. We'd want to have interviews with other people. We'd even want to have surveillance. I mean, think of some of the scandals in care homes where they've only been picked up because a relative or a journalist has put a camera into a room secretly, and then we've seen what's going on. So that's the sort of thing you might have to do to pick up coercion. But that isn't the sort of thing that's going to go on under the bill, and it's not the sort of training that people are going to be given, because they're not going to have the opportunity to put all of that into practice. The other thing to notice about the wording is that it's all about direct, overt coercion. But the worry about that is that a lot of coercion isn't like that. I mean, there can be coercion like that, but a lot of coercion is much more nuanced. In the committee stage, Professor Gareth Owen talked about subclinical cognitive impairment, subclinical depression, subclinical intellectual disability, and said how those things could interact with pressures within families so that the impairment and the interpersonal pressures would interact and amplify each other and would act as a coercive force. So being able to pick up that sort of thing requires quite a lot of sophistication. Being able to notice that somebody doesn't have a clinical depression, but nevertheless their mood is a little bit down. Meanwhile, there's some sort of subtle pressure from somebody in the family, and together those things mean that the person just feels that this is what they've got to do. Naz Shah, one of the MPs in the committee, talked about how coercion and controlling behavior can be very subtle. And she pointed out how the experts that had come to the committee had said it's very hard to spot. Rebecca Paul, one of the other MPs, said that only 3.7% of recorded cases of controlling or coercive behavior result in a charge. So these things are subtle. They are difficult to pick up. Rebecca Paul also cited Annie Donaldson, who's a domestic abuse expert from the University of Strathclyde, who emphasized how victims victims of coercive control often believe that they're worthless, that they're a burden, and that they would not be missed. And they're often told this by the person who is putting pressure on them. And there was a very interesting episode during the committee when Danny Kruger, another MP, was arguing that prisoners and homeless people should be excluded from the provisions of the Act. He made the point that these people might be at their most vulnerable, and in that state they will be very easily influenced, especially if somebody in authority, so a doctor or some sort of other health professional, was telling them that assisted suicide might be an option for them. He made the point that suicide can be contagious. So rather than coercion always being this direct, overt thing, it can be a subtle, less maybe covert thing. And the other important thing to recognize is that the passage of the bill itself creates a coercive force where being a burden, and we heard from Matt that being a burden is often a reason why people go for assisted suicide, being a burden becomes a problem that can be solved, a problem that can be sorted. I just want to read you the book which Sheila wrote brilliantly in, and which we were very pleased with because so many of the authors wrote so well. So one of those authors was a psychiatrist from Canada called John Maher. And so he's a psychiatrist working in a system where they have assisted suicide. And he said, it is the social acceptance and availability of assisted suicide and euthanasia that acts as a coercing force. Once euthanasia and assisted suicide are accepted, the social and political culture itself has a coercive force that is insidious and invidious. It also allows medical arrogance and ignorance to masquerade as benevolence. This coercive zeitgeist represents a coarsening of our relationships, our institutions, and our culture. I want to end then with some thoughts about, very minor thoughts about George Orwell. I did have an article published in The Spectator a few weeks ago about George Orwell and the bill. But so I'm thinking just here, just focusing on Animal Farm. And you'll remember that in Animal Farm, the animals come up with 7 commandments. So that these are the commandments such as all animals are equal. And the point about the commandments is that they're fundamental, and they're just accepted as being very obvious and the way people should act. But then curiously, those commandments changed. So all animals are equal became all animals are equal, but some are more equal than others. Well, in the Act, this is in the amended Act as it's come out, in section 29, it's talking about the Suicide Act. And it says a reference, so in connection with the Suicide Act, it says a reference to an act that is capable of encouraging or assisting suicide does not include providing assistance to a person to end their own life. So I wonder how the drafters could even bring themselves to write that sentence. So what it's saying is that that in the Suicide Act, a reference to an act that is capable of encouraging or assisting suicide does not include providing assistance to commit or to help someone to commit suicide. It's a complete negation of what the Suicide Act is about, as if this is a straightforward thing. And then finally, similarly, in section 38 of the amended Act, it talks about the National Health Service Act. So just a quote from the 1946 Act, that says a comprehensive health service designed to secure improvement in the physical and mental health of the people of England and Wales, and also what the bill is bringing, what that Act was bringing about was the prevention, diagnosis, and treatment of illness. So what the new bill says is that this now includes commissioned voluntary assisted dying. So bringing about the prevention, diagnosis, and treatment of illness now includes voluntary assisted dying, which again seems to be a complete change, something that's just suddenly occurred, but we ought to see what a fundamental change it is. It's a bit like saying no animal should kill another animal unless you have to, which is the terrible thing that happens in Animal Farm and the terrible thing that we are now considering. Thank you very much.
Wow. Well, thank you for connecting us back to Animal Farm. Some very interesting points there. Thank you. Our third and final speaker tonight is Dr. Philip Howard, who's a recently retired consultant physician and a senior lecturer in medicine, former member of the Council of the British Medical Association and a member of the BMA Consultant Committee. Philip has a particular interest in medical law, and he's going to talk to us about the change in practice of medicine, reversing the declaration within the Hippocratic Oath. So over to you, Philip.
Well, thank you very much. I attended the committee every day, twice a week. I wanted to know and understand what it was all about. I wanted to hear from the very people who were going to change the law in such a fundamental and seismic way. One of the first things, of course, that happened was Kim Leadbeater gave up on having a High Court judge to oversee the process and the abolition of Clause 12. Second turning point for me, listening to the discussions, was something that was said on the 11th of February by Kim Leadbeater herself, after Jenny Kruger had said that what we were talking about was not assisted dying, but assisted death. And I'd like to quote her directly. She said, "I do struggle with that terminology. This is not assisted suicide by the state. The state is not involved. It is the person making an autonomous decision based on their choice at the end of life. I will say on the record that the term suicide is not accurate for the cases we are talking about. The people we are dealing with are not suicidal. They very much want to live. They do not want to die, but they are dying. It is important that we have that on the record." I entirely agree with the first and last sentences. We struggle with the terminology, and it is important that she put that statement on the record. Going back to George Orwell in 1984, he said, "If thought can corrupt language, language can corrupt thought." And I think this is a very good example of that. Was she correct? Are we talking about assisted suicide? Clearly we are. She is in denial of that. It is a very confusing and contradictory statement. She is concerned about what she is doing. And anybody who may subsequently be involved in assisted suicide will suffer from what psychiatrists call moral injury. I think I sensed denial in her statement, and also the sense of moral injury. If this becomes law, and our parliamentarians are responsible for thousands of deaths per year. As has already been said, a further turning point for me was the change in the 1946 NHS Act and the 2006 Act. The 1946 Act put into statute law the very constitution of our NHS, what we all approve of, as does the public. And it is a tremendous privilege for me to be able to see any patient, to make a diagnosis, to treat that patient without any consideration of the cost to the patient. But has already been said, Clause 38 now states that we must add into that provision of care and health for patients the idea of the voluntary assisted dying commissioner, so that our NHS will alter the 46 Act and will allow for assisted dying. No longer just healthcare, but the actual taking of the lives of patients. Going back to that rather confused statement of Kim Leadbeater, which I've thought about a lot, was there in a sense an element of truth in it when she denied she was talking about assisted suicide and was talking about assisted dying? And was she perhaps moving towards voluntary assisted euthanasia? We see a little of this in the confusion in section 23. As has already been said, if a doctor prescribes something, it is taken by the patient as a sign of approval. But clause 23 says that the doctor may prescribe the medication. The doctor may supply it in person. The doctor can prepare it. The doctor can set up devices such as intravenous drips. It also says that the doctor may assist the person, not the patient, it's the person, to ingest or otherwise self-administer the substance. This really came home to me when Danny Kruger asked Stephen Kinnock how far you could go in giving oral lethal medication. You could sit the patient up. You could hand them the lethal medication. You could help them to raise their hand, but you couldn't get them to tip their head back so that the medication would go into their mouth through gravity. That is pathetic. Everybody who had heard that would know that effectively that doctor is assisting that patient to kill themselves. But the clause says that the patient must ultimately take the substance provided themselves. It's very difficult to understand what that means. And perhaps going back to the Leadbeater comments, we are not really just talking about assisted suicide. We will very soon be talking about assisted euthanasia. My further concern was when an academic lawyer from Christ Church College, Cambridge, and Lord Sumption said that there is no problem here with human rights and Article 2. A very surprising statement. I've never heard a lawyer, much less a retired Supreme Court judge, to dismiss something so easily and so quickly within a few sentences. So I looked at the case referred to by Dr. Lewis Graham, Mortier versus Belgium, in October 2022. That was not a landmark case. The further case was Karzai versus Hungary in June 2024. I was worried that those lawyers had not considered that. In his judgment, Judge Sagodes in Belgium emphasized the importance of Article 2. And that was taken up and agreed with by Judge Wodacek in the case of Karzai versus Hungary. And I will summarize, therefore, what Judge Wodacek said. He said, if you have a law or a statute or a convention which is simple and straightforward, it does not need interpretation. Article 2 states, everyone's right to life shall be protected by law. Is that a difficult statement? Is it complicated or is it simple? It goes on to say that no one shall be deprived of his life intentionally, except for the exceptions in Article 2.2, none of which apply in medicine. So what Judge Wodacek was saying, that the fundamental right to life is simple, straightforward, does not need to be interpreted in a medical context, and should be taken for what it is. The very foundation of our human rights. And he made the point that if you do not have a right to life, which is priceless and fundamental, then you can have no other rights. And contrary to what happened in the debate time and time again, Article 8, the right to a private life, a qualified right, has been taken by Kim Leadbeater to overturn the fundamental right to life. Now think about that. If you have no right to exist, you have no other rights. The right to life is inherent. It cannot be taken away. It cannot be conferred. It exists by the very fact that you are a member of the human family. It's intrinsic, it's equal, it's universal, it's non-discriminatory, it's inclusive. It cannot be taken away. The one thing that was not heard in committee was the fundamental denial of the right to life. But this bill will also overturn our Hippocratic tradition. In the Hippocratic Oath, we have that the purpose of medicine, wheresoever I shall go, whosoever house I enter, there will I go for the benefit of the sick. And as the late Luke Gormally said, that simple concept of benefiting the sick has four components. First, to save life where possible. Second, to treat disease. Third, to give palliative care for those who are suffering. And fourth, to restore as much as possible, as has been very eloquently described this evening, mental, physical, and spiritual well-being. As Dame Cicely Saunders said, those who are dying have got an awful lot of life still to live. When we are dealing with the dying, we are dealing with one of the most important things in medicine, something which we cannot ever fully master. Because first of all, every single patient that we deal with is a unique individual in imago Dei. They have particular circumstances and difficulties that we have to tackle. It is very difficult because it deals with that profound existential problem that we all have. We all have to face the issue of death. We are not simply dealing with a procedure or an operation or a condition. We are dealing with something that will shortly affect us all, namely our death. Thirdly, it is not a one-way conversation. It is a two-way conversation. We listen and hear and experience and know through our sympathy, I hope, and empathy even more, what the patients are experiencing and what they are telling us. And that goes into our personal practice. But over the years and centuries, it has gone into the wisdom of the medical profession throughout the world and has cemented the trust and confidence between the public and the profession. And the fourth thing is that whatever we say, whatever we do, however we behave, I'm sure in practice, a lot of us forget those who have died very shortly. We remember a few. Henry Marsh, who was a colleague of mine, quoted in his book that a French surgeon in the 18th century who said, from time to time, we must all visit our personal cemeteries. We do remember a few of our patients. They do teach us. But I can tell you that although we may forget what has gone on, the families, the friends, the relations remember. They can remember a good and peaceful death. They can remember when you have done everything that you can to help that person. But sadly, very sadly, as will be brought out if this bill ever becomes law, they also remember, and it becomes ingrained, and they never forget when things have gone wrong, when people have suffered, when we haven't tried to do our very best for those people that actually require most of our help. I hope that this issue brought into Parliament and into society by Kim Ledbetter will be defeated, either at the end of April or the middle of May. I hope it will be defeated. But I also hope very strongly that this debate in Parliament will bring all of us to know and care and understand and appreciate what is needed in medicine and what is needed in palliative care. I am an incurable optimist, and I hope good will come out of this debate. Thank you.
Thank you very much, Philip. I'm an incurable optimist as well, so you're in good company. We're going to have an opportunity in a moment just to reflect on each other's contributions, and then I'm going to ask Professor Peter Hindmarsh, who's Emeritus Professor at UCL and Chairman of the Catholic Union Charitable Trust, to tell us about the questions that have been asked. But let's just reflect ourselves for a moment. I have a couple of reflections. One of them is that I don't think anybody's spoken about the actual kind of prescription. As I can see, looking at the bill, it just says that the Secretary of State will determine what medication protocol will be used. And as I understand it, there is no kind of approved protocol anywhere in the world, that there isn't actually a magic potion that can kill somebody, bring about their death straight away without complications. In Oregon, I think it's something approaching 7% complication rate. And I believe in the Netherlands, they prefer euthanasia because it's otherwise the attending doctor has to wait an awful lot of time waiting for the person to die, and it's quicker and easier for them to do it themselves. So, this whole issue about whether euthanasia is actually the direction that we're heading in, I think is a really, really important one. But so there's that question. But the other question that I have is the reason for this bill and the amount of interest in it really because we haven't sorted out end-of-life care properly in the community? Because most people say they want to die at home, right? My husband died at home recently. I was absolutely unprepared for the complete lack of coordination of the services that are actually available, but which are poorly coordinated. And therefore, I had to be the coordinator. Well, I'm a retired psychiatrist, a retired GP. I managed to work it out, but it was jolly difficult working out which number to call when and what expectations to reasonably have. That's not good enough. And so I think, if we got end-of-life care sorted out, would we actually be having this debate at this time? So I wonder what the panelists think. And then I'm going to ask Peter to introduce some questions from the audience.
I can start off, Baroness Hollins. So I guess not to talk in too much detail about the medications on your first one, but in Oregon, they've changed the recipe, if you like, 4 times. It's about 3/4 of a pint, so it's more than most people think. And within those medications, you have an opioid, a barbiturate, and often a muscle laxant, succinylmethonium or something, and then the lethal agent, which is normally an arrhythmic, digoxin or something like that. And it's And essentially what they're doing is you're making you very, very sleepy, you're paralyzing yourself as much as able, and then you're making your heart go into an arrhythmia with the oral things, or with the oral ones. You're absolutely right. Euthanasia by IV injection, I think it's something like 98% made. Medicines isn't there in Canada. By far is more used because it's someone giving you something, and therefore it feels more, I guess, medical. The problem with the oral assisted suicide of drinking a 3-quarter pint, I think the complication rate's slightly higher. I think it's 15%. And the complications are generally because you're drinking something really caustic and you're nervous, that vomit it up, and they get a partial dose. And if you get a partial dose, the length of death can be much, much longer. So it can go up to 146 hours is what the sort of length of time is, which is over a week. And the average is longer than the euthanasia giving it IV. In terms of your, sorry if that's horrible to everyone, but that is the practicalities of it. It is the same as the lethal injection and capital punishment, essentially. The second question about palliative care, you're absolutely right. Just to say some numbers, Sue Ryder did a report. Palliative care is only 37% commissioned, so it's majoritively charitably funded. So you've got a situation which is both ironic that charities will fund palliative care, but that assisted suicide will be commissioned by taxpayers. You would pay it. And I'm sending a very skewy, to use George Orwell, doublethink kind of message there. And the thing is that I think you're absolutely right. If we had proper palliative care, coordinated across the service, fully integrated, not seen as this luxury top-on, then we would be able to address a lot of the fears that we go look after the people.
Okay. Do any of the other panelists want to comment on anything that anybody has said before we throw it open? Just a short comment, or should we hear from the listeners? And to people who are listening, do add your questions.
Can I make a quick comment? I promise to try and keep it quick. So I think I'm very interested in Philip's comments about that fundamental right to life. I think that's very important to consider. It comes up against those people who argue that we also have a right to death or a right to die or whatever. That's a complicated argument. I mean, I don't think we do have such a right, but we need to kind of face that to some extent. I think this whole business about the tablets that you have to take feeds into the myth that I think is very important in the minds of a lot of people, which is that assisted dying is going to be some sort of nice event which your nice benevolent GP will turn up and give you one tablet, and then you'll just nicely slip away. And as Matthew's outlined, it's not going to be like that. It's going to be lots of tablets. Might well be side effects and so forth. And then to come back to your second question, I thought I mean, there are the problems with palliative care, but I also think there's this kind of broader problem to do with medicine more broadly, that actually all doctors ought to have palliative care skills. We don't all have to be palliative care specialists, but we all ought to be able to deal with people dying. And I think that we've lost a lot of that somehow, for some reason. Maybe to do with Shipman, but I don't even think it's to do with Shipman necessarily. I think people have just kind of lost sight of it. I remember as a junior doctor spending ages one day trying to doing all sorts of things to some poor person who was clearly dying, but the consultants involved said that we had to do everything possible to keep the person alive. It was a ridiculous thing to do. And so there's a kind of broader culture where doctors, medicine, healthcare professionals need to have a a better approach to death overall. Thanks.
Okay, very good. Well, thank you very much. Well, Peter, welcome. And you've been following the questions that are being asked. Do you want to make a comment first or start with the first question?
No, I think I might just start with the questions first of all, except to note, after having spent something in the region of 15 to 20 years advising the medicines regulators in United Kingdom and Europe, we've spent an awful lot of time debating there how to avoid a drug having an adverse event like killing somebody. So it's slightly odd to have this discussion where people are suggesting that we use the same medications that we've teased out over the 20 years or so to use them in this way, which is rather strange. And as Matthew rightly points out, there is no dosing schedule worked out. Obviously, you can't. And it's inevitably going to lead to numerous problems, I think, because of the route of administration, with the oral route. Matthew, I think I'm going to actually throw this one at you. It's kind of making a little bit of an assumption about palliative care. And so it's one of the first ones that came in quite early on during your talk, in fact, from Roshan. And what is being asked is, if this goes ahead and it's legalized in England, should it be restricted, you're not going to like this one, to palliative care consultants who confirm that all symptoms control has been exhausted, including admission to a hospice for a specified period of time? And I think this is actually touches a little bit on what Philip also raised, which is the question which came up a little bit further on, which is, okay, fine. So is the NHS going to do this? Because as people could argue that it's not part of their remit. They're certainly not funded for it. And the use of NHS staff to dispense and deliver this medication may hit a little bit of resistance. So maybe if you could just tackle the palliative care bit first of all, and I think it's probably going to be fairly clear what you're going to say, but go on, say it.
So, and then the second bit, Philip, please. Can I say two things? The first thing is that it belays a misunderstanding of the population and how you're dying, actually. So the first thing is that people fear that dying is painful and suffering. Now, I know from Oregon that it's not even in the top 5. It's 34% have pain or fear pain is the reason why they're accessing it. So it's lower than burden, lower than less able to enjoy life, lower than dignity. It's lower than all those things. Actually, the reason why, and I get distressed at the Commons where they talk about these awful cases as the reason why they're doing this, when in actuality, in real life, people acting assisted suicide are not doing it because they're in pain on the vast majority. In fact, Dignitas, the people who are going there, aren't accessing it because of pain either. It is a misconception. And even within the Commons, when we're describing these situations of awful deaths, it's ironic that they describe situations such as vomiting feces, unfortunately. Well, we're describing legislation in which they can drink it. So how can they do that? They describe situations of dementia, yet they wouldn't be eligible. So even the awful cases which they described in the Commons to justify this bill do not actually match the bill in terms of what fulfilling their own eligibility criteria in terms of things. So there's a real mismatch there. The second thing joins on to Dr. Howard's in the sense that there's a misunderstanding of the word dignity. And well, with palliative care consultants doing this, well, they're the ones which are the vast majority against it. 80% are against it, 50% are neutral, 5% are pro. For the APM surveys, 5 surveys over 10 years. And the reason is because those two principles, ethoses, come into combat. And it hinges around the word dignity, because in keeping with the UN Convention of Human Rights, and correct me if I'm wrong, I think the very first paragraph or so says there's the inherent dignity of all human beings. And this is in keeping with the Catholic Church. Whether you're a pauper or the Pope, whether you are a lawyer or a doctor, or you are terminally ill, you have the same invaluable human dignity. You are so valuable. As proponents use the word dignity as a kind of value system, as in that, well, I've lost my dignity. It's not worth me living because I'm less able to enjoy life. That's 87% said that because of the reason why. Or I've lost my autonomy. It's more about I've lost my dignity. And the job we have in palliative care is giving the dignity to the, no, you are worth infinite amounts. And I give you that dignity by treating you as you should be, and trying to give that person their true value. And therefore, palliative care see that in the hospices. We give those people that value, and that's why they realize, whoa, this is I have reason to live here. Whatever time is left, I've got reason to live, as opposed to the ethos of, no, it's not worth living. And that's why palliative care physicians won't do it, because those principles are completing conflict. I treat suffering, I don't kill the sufferer.
Thank you, Matthew. Very clear. Philip, do you fancy tackling NHS funding and resources, or should we throw that one at the politician? I think we've got... Philip, I think we've got a problem with the connection here.
The internet.
Philip, we can't hear you.
Yeah.
So you're going to have to sign
Start
out
again.
and sign back in again, I think, because you're coming over all jumbled. It's there's a connection problem. So could you sign out and sign in again? And Peter, perhaps you can move on to.
Yes, so it's maybe this one's for Julian. And it's about lasting power of attorney, and I think it might be a difficult one to answer this. How do you protect the vulnerable from those people who actually hold power of attorney over them?
In theory, it shouldn't be too difficult, because even if you have the lasting power of attorney under the Mental Capacity Act, which covers England and Wales and is meant to be the act that's appropriate to think about in connection with the Leadbeater Bill, even if you have the lasting power of attorney, you still have to act in the person's best interests. So anybody who felt that that wasn't being done should feel free to challenge it in the Court of Protection or whatever, and argue against somebody doing that. Now, I mean, that in itself might be difficult, because you might feel that you don't have the wherewithal to do that. You might feel threatened by whoever it is who has the lasting power of attorney. You might feel you don't want to rock the boat in a family where somebody who's slightly tougher than you has the lasting power of attorney, has taken the decisions, and so forth. But in essence, you ought to be able to go to the Court of Protection and say, the person with the lasting power of attorney is not acting in this person's best interests, and therefore it should be stopped.
Well, thank you very much. That's very clear. Philip, are you back with us yet?
Can you hear me now?
Yeah, that's great.
Okay, fine. Just a number of points. First of all, with regards to conscientious objection, that was actually dealt with in the bill. There was some doubt about it initially, but you are not required to participate in it. The question of referral to somebody else has now been reduced to having to signpost or indicate or give information about the service and not to make the individual referral to a consultant.
Sorry, I think we just missed that bit, Philip. Sorry.
Or GP. With respect to lasting powers of attorney, well, it's an easy one. Can you hear me now? Or?
Yeah. Let's come back. Yeah.
It comes. So it's not an issue for the LPA because the individual has got to agree at the time they take the medication to taking it. It can't be done by somebody else. So you can't have an advance directive to take lethal medication. You have to agree at the time that you take it that that is still your wish. So that would not be an issue.
Okay.
Is that
Good.
okay?
Yeah, that's fine. Thank you very much. I'm just checking through a few of the additional points here. Matthew, I think this is, well, everybody can contribute on this one, I think, which is really, it's back to this assessment of capacity and how that might be influenced by factors such as current pain, trauma of actually realizing what's the direction of travel is. And there are probably others, numerous others. Could you just outline those for us, just so people have got a feel for the complexity of assessing capacity?
Yeah, so I guess I was trying to outline the capacity assessment as per the Mental Capacity Act 2005 is not is to try and protect patients, and it's not and it's been used incorrectly here. I think it's been used in a way which, when you should say the word "the patient has capacity" as some sort of, oh, there must be okay then. But really what it's used for is when someone's going against medical advice and we're worried that they're confused and we're not sure that they can make that decision. If we do that check that they have the faculties to make that decision, they're allowed to do that. That's an unwise decision maybe, but they're allowed to do that. So it's to protect people who are confused, which is why at the very start of it, you assume capacity. However, in the assisted dying legislation, we bypass that completely. So it's completely mismatched. We are not assuming their capacity. We're using it as a sort of, it's, by the way, for listeners, it's basically 4 principles. You have to be able to communicate. You have to be able to understand the information. You have to weigh up the information, and that's about it. And it doesn't really get to the heart of it. Is to if you know what I mean, it's mismatched to the purpose which it's been applied for here. The another question which I thought you got asked, which I think is related, is about the if there's no brain function and withdrawal of treatment stuff. Just to mention that very briefly, there is the difference with palliative care is that I let nature take its course. I try and control what nature throws at us. But essentially, if we're artificially keeping someone alive, by withdrawing that, I'm returning to the natural course of events. So in withdrawing a treatment, I am letting nature take its course. I'm not speeding it up, if you like. Assisted suicide is different. I'm giving a lethal medication, so I'm killing them earlier on in the cycle. I'm actively intervening to kill them. As in withdrawing something like ventilation in that example, I am, well, actually, we are, the patient is dead or dying, and I'm returning them to a natural course of event and letting them die. So that is a real difference, and I don't think it's hard to articulate, but it's what is very, very a misconception across the entire spectrum. I do not try and force everyone onto life support machines, ventilations, and things like that. No, my job is to let nature take its course, but control what nature's throwing at us in terms of the psycho-spiritual, social aspects.
I think you put that very well indeed, Matthew. Thank you very much indeed. And it is probably important also for people to understand that capacity can change almost day to day. I might be a bit hacked off today and not very keen on life, but tomorrow, well, the sun's shining and it might be a different view. And things do change, and medications do change it as well. I think that's important to realize. I think there are.
Can I add to that, Peter?
Yes, of course. Yeah.
Do you mind? I just wanted to say, everything Matt said is great. I also wanted to add, though, that in the discussions in the committee, it was as if the Mental Capacity Act is all very straightforward, and the fact that we've got it there means that there's no real problem. If any question about capacity is raised, we just say, oh, let's look in the Mental Capacity Act. We have to remember, though, that the assessment of capacity can be quite difficult. Some people get a bit upset when that's said, and they say, oh, we're all assessing capacity every day. It's a very routine thing. And that's true. Capacity is being assessed every single day by all sorts of people. But there are difficult marginal cases, and those are the ones we have to worry about. And what we have to recognize is that although some people think of the Mental Capacity Act as if these are just factual things that we can tick off, and this is encouraged by the fact that we're given forms with tick boxes, which we can put our little ticks in. But the things that Matthew outlined, like deciding whether somebody's understood the information, deciding whether they're retaining the information for long enough, and so forth, these are all not factual things, or not just factual things. They're also evaluative things. There are value judgments that you have to make. And so that can make it difficult. And we need to recognize that difficulty and recognize that it can be quite subtle, and you have to be very careful when you're doing it.
Thank you very much indeed, Julian. That's a very wise comment there.
Can I just add,
Yeah,
I was a member of the Post-Legislative Scrutiny Committee of the Mental Capacity Act, and we actually found that it's not working well. It's all quite complicated, but it's actually very difficult to assess capacity and to use that act properly. And of course, it was never intended to be used for this purpose at all. So anyway, on to the next question.
Well, I think it's also just a statement, Sheila, that we've been talking about England and Wales, and sometimes the Catholic Union is slightly criticised for being a little bit English-centric. But we've had a couple of comments from Scotland as well, where they're facing the similar issues, and I hope that they'll find that this discussion useful, that the points that have been raised they can also put together and use to persuade the powers that be in Holyrood that maybe there's a different way of looking at this. I think actually, Sheila, we're just about coming to 10 to 8, and it might be useful, I think, I'll just check a bit further down, but I think we're reaching a point where we could actually draw things together, and a number of people have would like, I think, and this may be something we have to take away as part of the Catholic Union, would like some key bullet points to take to their MPs to provide a view that they need to consider. And I think, actually, we were talking yesterday, weren't we, Sheila, about the new intake of MPs, large numbers, many not quite au fait with the ins and outs of how Parliament works, but also perhaps not au fait with some of these critical issues which have been thrust upon them. And I suspect that some may have a view and will not be changed, but quite a number, I think, would welcome a well-argued case. And if you would find it useful, we'd be more than happy to put together a few bullet points. We'll tap these extremely good panelists to help us with that. But 3 or 4 good, short, well-argued points, I think, would go a long way and might help sway the undecided. We'd have to sway very many.
Yes, and I think the point here is that, even if your MP, even if you've already written to your MP, and even if your MP voted in a particular way previously, it's still worth engaging and talking and raising the issues that you think are most important. So I think it would be terrific to hear from each of the panelists what you think. I've already started compiling my list, but let's hear from you. What would you say, Julian? What would your top 3 take-home messages be? What should you go to your MP and say?
Well, I'm so pleased you asked me to go first, because I'm going to steal one of Matthew's points and say that you have to think about the number of unexpected deaths, and because I just think that's a very important point. We weren't happy with it happening when people were being executed. Why should we be happy with it happening now? Second point, I think, would be, since I spoke about palliative care, which is also Matthew's remit, but would be to say that there's a lot more that can be done with palliative care in terms of getting it to more people, in terms of improving the quality, in terms of improving the research. And then the third point would be, I think, something to do with, well, I hope that maybe Philip or Matthew will focus a bit more on the bill that will be presented for the third reading, the sort of amended bill, whereas my final point is just the more general one about that we were just making about capacity and coercion, and just the worry that both of those things require some subtlety. And I'm not sure that just saying, oh, use the Mental Capacity Act is good enough for the reasons that we outlined just a second ago. And by the way, as well as that very important report from the House of Lords looking at the working of the Mental Capacity Act, there have been several other research studies since then which have also said that actually professionals still aren't using the Mental Capacity Act accurately. So we have to recognize that capacity is a subtle issue, and that also coercion is a subtle issue, and it's not going to be sorted out by giving people half a day's training and saying, oh, you'll be able to pick it up now. So that would be my third point.
Well, your second point, which was about better kind of palliative care, better end-of-life care, I mean, putting it in very straightforward terms, if you're going to your MP to say, for this constituency, can you ask the people who pay for healthcare locally to actually pay for for the NHS to pay for end-of-life care for everybody who wants it at home, and to make sure that it's properly coordinated? That's a really straightforward ask, isn't it?
Yes, no, I think that's right.
I think that's what you were talking about. Great. I think that would be absolutely a top one. So who's next?
If I may make a few suggestions while I'm still on the internet, I hope. First of all, this is not a new idea. And the first euthanasia bill actually came to the House of Lords in December 1936. Yeah. And another one in 1950, 14 years later. And I've read through the statements. The arguments are essentially the same as they are now. This is not new. And I think a lot of people feel that it will eventually change. We will eventually get it. We won't. The other point I would make is that there hasn't been an impact assessment. It hasn't been properly scrutinized. It is full of contradictions and difficulties in practical terms. And it has been pushed back 4 years around the time of the next election. And I know that a number of faith groups, including the Muslims, but also those without any faith, are against this on a matter of principle. And that is certainly going to affect a lot of MPs. It is also going to affect, if it is ever enacted, which I hope it isn't, the next government, the Labour government. And also, I think that there is a serious question about coercion and undue influence. And one of the things that Naz Shah made very clear is the effect of domestic abuse and violence, which I personally wasn't aware of. And I think that this could very well be used for those that have terminal illness as a legal means in to domestic abuse and violence. About a third of the deaths are from homicide, roughly a third are suicide. And this would be a means for those that are suffering abuse, and if they got a terminal illness, to have.
Oh, we're losing you again. Oh, look. I think we're losing you, Philip.
Or conversely, a medically assisted homicide. Okay, fine. Can you hear me or not? So there would be a question of actual coercion and undue influence by those that are being abused in a domestic context. And I wasn't aware of how widespread that was. So those would be my points.
Brilliant, thank you. And Matthew, three quick, straightforward
ones. So I would say the gun, I've talked to a lot of MPs, and the one which, a few which have resonated with me, along with everyone else's, what they've said, is comparing to the gun lobby. The gun lobby is lethal weapons, NRA in America. You've got a gun, the right to carry a gun, and there is a societal consequence of that, which is more deaths, more accidental deaths, more violent suicides compared. So by introducing lethal medications into the mix, you are actually going to have societal consequences to it. And just really straightforward, this is going to happen, and there's going to be scandals related to that. The other second point is really hinging on autonomy, in the sense that people say, well, I may want it. But then you say, well, how about your mum or dad or sister or son or daughter? They can access this without telling you, because it's purely based on individual autonomy. You're not involved in the conversation at all. Oh, I wouldn't want that. And they realize that if it's purely based on John Donne, No Man's an Island, then they are completely isolated on that, and everyone can access it, not just yourself. So separate themselves. The third would be really, I would argue about the process and say, is this a good way to make law? Is a private member's bill? I encourage anyone to watch the committee. I've really got nothing to hide with it. I can't see how any reasonable person can watch that committee and not be appalled by the 15-8 constantly, and how the debate goes. They rejecting everything really to make it safer, and so I encourage them just to watch it and to ask them to what they think, and be very bold. My fourth is the same as Julian's. How many incorrect deaths are acceptable for this right? For you to feel like you've got this option, how many people should be put under pressure and burdened and coerced?
Okay, brilliant. And Peter, I'm sure you've got some. And then we need to call to a close.
Yeah, I think it's really difficult to add to the experts we have here. At one point, I was going to ask the panelists, but we don't have time. Is really okay, yes, look, it goes through and it happens, right? What support is there available for people who are left, who've been associated with this decision, and who might, in grief, get into that, well, what if I'd done X, or what if I'd said Y? Would it have changed things? And that may be a very difficult thing for people to live with. And I don't think people have considered, yeah, okay, there's the person who will die, but also there's going to be a lot of people, as you rightly said, Matthew, in terms of the relative example you gave. There's going to be quite a lot of people who may have quite a serious and severe grief reaction to what's happened.
Yeah. The families left behind, families and friends who may not have been consulted or involved. This is going to potentially lead to complicated grief. I speak here as a psychiatrist. We are going to have to draw to a close. I want to draw your attention to something in the chat, a letter drafted for women of faith, and those interested, you can contact the person mentioned in the chat if you would be interested in knowing more about it and signing it. I think there's a link there as well. Just to say, when the third reading, if it goes through, yes, it will be quite difficult for the House of Lords to change it, but it has to go through all the same stages in the House of Lords. It'll be on a Friday, I guess, because that's when private members' bills are heard. It'll be co-sponsored by Lord Faulkner, who's already had a bill himself in the House of Lords, which was turned down. The House of Lords isn't very well organised at the moment because we've got a new government and a new opposition who haven't really quite settled into their new roles. So it's all a bit unpredictable. However, what is likely to happen is that there'll be attempts to amend the bill. And so the question I would have asked the panellists, I think, probably would be, you know, what amendments might make it better if indeed it is going to get through. Okay, so it's something to think about, and maybe you can all let me know what amendments I should be putting forward. Because, you know, amending a bill, and that's what the House of Lords does, our job is to scrutinise legislation. We usually amend it and send a bill back better than the bill that came. You know, it's hard to imagine that, you know, one would want to engage in that process with a bad bill, a bill that's not fit for purpose. But if we are presented with, you know, a vote at third reading in the House of Commons, which says the majority of MPs want it, then that is our task, is to amend it. Okay, so that's the thought. And with that, I think all I can do is to say thank you very much to all of the panelists, and thank you to everybody who stayed and listened and asked questions. And please go and see your MP if you share the same views as the Catholic Union, that this is a bill that shouldn't be happening. You know, we have to talk about it. We have to talk about death and dying. We have to talk about what we actually want to happen, what would be better to happen. And, you know, I hope that today's discussions will be helpful in moving everybody's thinking forward. So thank you to everybody, and good night.
Thank you very much.
Thank you. Thank you.